My name is Dianna Vermilyea, and my project was on identification, treatment, and referral of victims of human trafficking using an evidence-based approach. And at this time, I would like to acknowledge my project committee chair, Dr. Bernadette Dupre, and my committee member, Ms. Melissa Harris. Dr. Dupre has been instrumental regarding insight and advisement on my project, and I am very grateful for her leadership and her guidance. And this project could not have been possible without the support and the advocacy of Ms. Melissa Harris. I am grateful to both of you, and I owe you enormous accolades. Dr. Holcomb, thank you for your assistance with my data and for reassuring me that I understood what it was telling me. And I would also like to take the moment to thank my family, especially my husband, Scott, for his eternal support and encouragement. So just a little bit of background about human trafficking. Human trafficking is a global health crisis, and it occurs at the international, the national, state, and local levels. And victims are often those who are economically or socially vulnerable. So people who are impoverished or live homeless, abused or neglected homes, disabled, and also our LGBTQ community. The exact number of victims is unknown, but estimates are at least 40.3 million people worldwide trafficked. It is a multi-billion-dollar criminal industry, second only to drug trafficking in the United States. And human trafficking in the United States is often thought of as a problem that exists in urban or suburban areas. However, this crime has infiltrated rural areas where it's more difficult to detect and where there are fewer community resources for victims. There are also fewer law enforcement resources, and often you have community members that deny that human trafficking could happen in their community without their knowledge. Rural human trafficking cases tend to be coordinated by a victim's family member rather than strangers, and it's usually to pay a drug debt or to purchase illicit substances. Many human trafficking victims are seen by medical professionals during their captivity, but few are identified as victims of human trafficking and provided with appropriate care. The emergency department is the most utilized medical area by human trafficking victims. Healthcare professionals lack knowledge and training to care for this specific population. So it presents a very significant barrier in meeting goals and outcomes for the patient who is human trafficked. And this led to my PICO question. In emergency department nurses of a rural hospital, how does the implementation of the SOAR training module compare to current interventions to improve the knowledge and self-efficacy when identifying, treating, and referring victims of human trafficking over a 6-month period? And SOAR simply stands for Stop, Observe, Ask, and Respond. So regarding the implementation for my project plan was to do a pre-test survey, have my participants complete an online SOAR training module, and then do a post-test survey. My intervention initially included 3 online training modules, and these modules are maintained and updated by the United States Department of Health and Human Services Office of Trafficking in Persons. I did have to make some adaptations from the qualifying exam proposal. I reduced the number of modules from 3 to 1. I extended the due date of the modules for 2 weeks. And the project site was kind enough to provide incentives to encourage completion of the modules by the nurses. And I just wanted to make a note also that the modules themselves are created by experts in human trafficking as well as survivors of human trafficking. So regarding the project variables and measures, my 2 dependent variables, what I was measuring, what I set out to measure in this project was knowledge and self-efficacy of the emergency department nurses. My independent variable that I used was the SOAR online training module. And then methodology, this was a quality improvement and education project. And the DNP project was introduced to 4 different shifts on 2 separate days. And I did this to try to make contact with as many nurses as possible based on their work rotation, because they basically worked in shifts, 4 different shifts, 2 day shifts, 2 night shifts. So I tried to reach as many as I could. The study itself was primarily a quantitative study with a few qualitative questions. I did the pre-test survey, which was comprised of 11 questions. The first 5 questions were very basic demographic questions, and the last 6 questions were slider scale questions, very similar to Likert scale questions. And these questions asked the survey participant to rate their knowledge and their confidence level related to identifying, treating, and referring victims of human trafficking on a scale of 0 to 5. I had 21 out of 24 pre-test surveys that were collected in paper format. And the other nurses that I did not get to that day, 3 of those nurses did their pre-test survey by scanning a QR code that I created in Qualtrics. The post-test survey was very similar to the pre-test survey, but of course it did not include those demographic questions. In addition to repeating the sliding scale questions, there were open-ended questions that provided qualitative data about the participants' past exposures to education about human trafficking, as well as a question regarding how applicable they thought that SOAR module was to their current nursing practice. Participants were also asked to describe their experience in working with victims of human trafficking. And I inputted all of my data into Qualtrics, which is an online assessment tool that allows users to build surveys, collect information, and analyze data. Looking at my short-term and long-term goals, while the short-term goal of 50% completion of the pre-test survey was reached with an 85.7% of participants completing it, the long-term goal of 95% completion of the pre-test survey was not met, and it stayed at 85.7%. Neither the short-term nor long-term goal for completing the modules was met. At 3 months, I had 0% of the modules completed, but at 6 months, I had 29.2%. It still fell short, though, of my 95% goal. I had 50%, my goal was for 50% of nurses to complete the post-test survey, but obviously if they didn't do the module, they couldn't do the post-test survey. So my short-term percentage was 0 and not met. My long-term goal of 95% completion of the post-test survey, I only had 16.6% completed, and this indicated that participation was low. It's important to note that all of the post surveys were electronic due to pandemic concerns and an increase in patient census. And I really felt that I would have had a higher response rate if the surveys were in paper format. Now, regarding the last goal of utilization of the policy and treatment protocol, the integration of the screening questions and the human trafficking policy and protocol have not yet been implemented at the project site, which is why I have 0% and my goals are not met. They are currently awaiting review and approval from the emergency department committee at the project site. My ultimate impact for this goal was to improve the knowledge and self-efficacy among the emergency department nurses when identifying, treating, and referring victims of human trafficking. And my overall end goal is truly to increase the number of human trafficking victims who were assisted and referred to community resources. So I did some data analysis of my demographic variables, and you can see from the gender that a large portion of my participants identified as female. I think I had 87.5% identified as female, while only 12.5% identified as male. If you look at the age pie chart, you can see that a majority of the nurses were between the ages of 25 and 44, represented by the large dark green piece of the pie, as well as the large pink, dark pink part of the pie. And that was 70.9%. I also asked them about their years of nursing practice. And you can see from the bar graph that a majority of the nurses, and it actually came out to 75.1%, had 10 years or less as a nurse, as in practice. And it was the same for the years of emergency department experience. I had 79.1% of the nurses with 10 years or less of emergency department experience. And this data and the gender and the age demographics really illustrate for me, and as well as anybody reading this research, that there was a great deal of homogeneity among my participants in the study. So looking at the descriptive statistics of the pretest, you can see that N was 24. I looked at the variables of knowledge in identification, treatment, and resources, and I looked at self-efficacy of those same elements in identification, treatment, and resource. And I think what jumps out greatly is that on a scale of 0 to 5, with 0 being not knowledgeable or not confident, and 5 representing very knowledgeable or very confident, that the minimum that participants selected was 0. So there were participants that had no knowledge and no self-efficacy in caring for this population. It is also very evident in the mean. I had a mean average of 0.71 to 1.33 in these questions. I did have one outlier that had previous education who scored these higher scores for the maximum level. But the participants were asked to rate their knowledge and self-efficacy on the topics of identifying, treating, and referring victims of human trafficking as separate items on the pretest. The scale gave participants a choice on a sliding scale of whole numbers between 0 and 5, with 0 representing not knowledgeable or not confident, and 5 representing very knowledgeable or very confident. And the mean values for all 6 questions in the pretest survey indicated that as a group, the nurses rated their knowledge and self-efficacy of identification, treatment, and referral of victims of human trafficking as minimal. And the project findings regarding self-reported levels of knowledge and self-efficacy before any education or training are consistent with findings from multiple studies in the current literature, which indicated that there is a deficit of knowledge and low levels of self-efficacy across many disciplines of healthcare professionals when identifying, treating, and referring victims of human trafficking. If I look at the descriptive statistics of the post-test, you can see that my N is 4. So I did not have a big return for the post-test, but it was due to COVID-19 pandemic and challenges with staffing and an increase in the patient census. We had a big influx of the Delta variant at this time during the DNP project. And I think what jumps out the most in these descriptive statistics for me was that now the minimum scale of the participant selection is no longer 0 after the intervention, it's now 3. And then consistently 4 and 5s for the maximum. And of course, the mean has increased from the minimum levels of 0.71 to 1.33 to now 3.5 to 4, which I think spoke volumes, even though I only had 4 participants. So despite the low number of participants in the post-test survey, the findings of increased knowledge and self-efficacy were still of interest to me, because this demonstrated that 4 nurses felt more knowledgeable and confident in their practice regarding the care of human trafficking victims. And this increase in knowledge and self-efficacy will hopefully translate into changes in their nursing practice to improve treatment outcomes for victims of human trafficking. Now, I did a paired samples t-test, And again, my N is 4 because I can only take the participants who participated in both the pretest and the post-test survey. And in the paired samples t-test, you can immediately notice that all of the means are negative. And these negative means for each pair of variables indicate an increase in the knowledge and self-efficacy for identification, treatment, and the referral process collectively in the post-test survey when compared to the pretest survey. If you look at the Cohen's D for all 6 pairs of variables, it indicates a large effect size between the pretest and the post-test survey means, which just further supports that there was a significant difference in the pretest and the post-test survey results. Now, the paired samples t-test demonstrated that one pair of variables, and we're talking about variable pair number 6, and this was a pretest and post-test survey question regarding the self-efficacy in referring victims of human trafficking through resources. And it was statistically significant in a two-tailed p-test, p equals 0.022. All other pairs of variables were not statistically significant, with p-values of greater than 0.05 and a confidence interval of 95%. Now, despite the small population represented in the paired samples t-test, it's important to note the substantial difference in the means for the pretest and post-test surveys, indicating that self-reported learning occurred and self-efficacy developed after the learning intervention for those participants who completed the post-test survey. Some recommendations and implementations and sustainability that I have planned for the project. The project purpose truly addressed the practice gap of low knowledge levels and low self-efficacy when providing care to victims of human trafficking. This project supported evidence of increased levels of knowledge and self-efficacy in participants who completed both the pretest and post-test surveys. And this was congruent with findings in the literature. This project is applicable to any healthcare setting where human trafficking victims may go for treatment. And as far as practice change and sustainability, we know that nurses experience practice change as a core component of nursing. It occurs frequently. It occurs over all specialties of nursing. So sustainability is going to depend on thoughtful planning, engagement of learning, and communicating the rationale for and the outcomes of practice change with the nurses. And I have left the tools on board with the project site to continue training about the care of human trafficking victims. My dissemination plan is as follows. I have already presented to the Monroe County Health Department. That was earlier this month. I am due to present to the Loudoun County Health Department next month, as well as all women's care OBGYN office in Maryville. I also am presenting to the nursing faculty at Tennessee Wesleyan University this month. I have already presented to the senior nursing students at Tennessee Wesleyan University as part of their research class. My future plans for dissemination include the American Organization for Nurse Leadership. This is the Knoxville branch in Tennessee. And I have already spoken to the president of the Tennessee Nurses Association District 2, and I plan to present in January for them. I plan to present at Sigma Theta Tau International ROMU chapter in April. And I also plan to present to the Monroe County Health Council, law enforcement agencies, as well as to public schools. The DNP project addressed all of the DNP essentials, and some of them were very specific to my project. The focus of my project truly helped to eliminate health disparities and to promote patient safety, which addresses essential number 2. It also addressed gaps in the care of the human trafficking victim population, which addresses essential number 7. I continue to be extensively appraised of the literature, which addresses essential 3. I became proficient in using databases and extracting data, which is essential number 4. I had the opportunity to become involved in the process of policy creation, which addresses essential number 5. And probably the most important is that I experienced personal and professional growth in the area of advanced nursing practice, which addresses essential number 8. The project helped me to form a partnership with a healthcare organization and offered me the opportunity to support other nurses in learning more about human trafficking while improving their self-efficacy in caring for this unique population of patients. And I am happy to share the references that I used for this presentation. And I am also happy to take any questions that anyone may have.
Thank you, Diana. We'll open it up to your committee.
Well, good job, Diana. I know it was a difficult journey with the pandemic and the impact on the emergency department. And I think as nurses, we totally understand that when there's a large patient influx to the ED, it's hard to provide education or go through that process. So I commend you on your having the 4 post-tests and doing the SOAR modules. That's was an accomplishment compared to what you were dealing with. So don't be discouraged, because I think you've made a big impact regardless of the sample size. And I think the process and your journey was a tremendous growth during the course of the 2 years that you were working on this project.
I developed a great amount of emotional intelligence, and especially since I took the long route of 4 years in this program. So, and I think that the fact that I was not employed at my project site, I was not part of that network, it was difficult to engage the nurses and help them to see the value of the project, because they really didn't have anything vested in it. Whereas I had my entire life for the last 4 years invested in it. So that was, I think, a barrier.
I would like you to mention the Red Sand Project. Just
oh, sure, yeah. So there's an organization called the Red Sand Project, and what I did with my students is I actually bought some red sand because it was cheaper than getting it for free. I don't know how that worked. It had something to do with a lot of cost for shipping, but I got red sand, put them in small bags, and we went out and we poured red sand in the cracks of the sidewalk. And this is actually a national movement. I posted pictures on my Instagram and my Facebook account with the students' permission. And it really recognizes those victims who fall through the cracks of healthcare. So, and we utilize red sand because it shows up really well. So, and it's still there. We did it a couple of weeks ago outside of our nursing building, and it's still there. It has not washed away and it has not blown away. So,
well, and it gets the conversation started.
It does.
That's,
yes.
That part. Good job on your presentation. Thank you.
Thank you. Any other questions? I'll tell you anything you want to know about human trafficking.
Diana, this is Dr. Jackson. I think that you are an excellent example of someone in the DNP program where the emphasis is on the journey and not necessarily the destination. So while you had some foibles and obstacles that you had to go around or under or some sort of preposition, you became a great leader through growth of those challenges. So congratulations.
Well, thank you. That did take a lot of reminding from Dr. Dupre, because every time I didn't get some responses back on the survey, I just wanted to pitch a hissy fit, but I didn't. So.
Well, and I think despite the return on the survey, your support from the clinical site, they offered incentives and celebrated success when someone was able to complete the project.
Yes.
And incentives to complete the modules. I think it will be maintained going forward now that things are a little better as far as census.
And Melissa was truly a champion for me at the project site. And she says, well, what do you need? How can I help you? So very instrumental in helping me. So I appreciate her very much.
Thank you, Diana.
Thank you.
If you wouldn't mind stopping your screen share, then
Sure.
we can have Casey